All right. I think maybe we're at a good place to get started. And then as folks jump in, if they have any questions, we can, circle back to them as we go through the presentation. Um, so hello, everyone. Thank you so much for joining us today. We're thrilled to connect with your family and health special interest group to explore the collaborative care model for pediatric patients and their families. I'd like to extend a heartfelt thank you to the Family and Health SIG, but also to Patricia and to Hannah for inviting us and their efforts in facilitating this collaborative space. We're really excited to share insights and engage in meaningful discussion about how the collaborative care model can enhance care for pediatric patients and their care teams as well. Your participation is invaluable, so by all means, we definitely want to hear from you as we chat today. And if you have some questions, we'll definitely have some space for that as we go. Um, so the team presenting today includes Virna Little, the co-founder to Concert Health and Chief Operating Officer of Zero Overdose, and then myself. I do want to give Virna an opportunity to just introduce herself, though, and then I can tell you a little bit about myself as well.
Hi, thanks everyone. I'm really excited to be here and echo Nicole on the excitement around the collaboration. So I'm a psychologist and social worker by trade, have been doing collaborative care for a really long time on the CFHA board, and so very invested in CFHA and really promoting and supporting all of the SIGs and the work that happens across the organization. So thank you for the opportunity.
And my name is Nicole Portrude. I'm the Director of Health System Implementation with the Meadows Institute. I am a proud CFHA and CoCM SIG member. So excited to have this crossover experience. My background is in clinical psychology, and I've worked in integrated care for over 6 years now. I've supported in the behavioral health care manager role. I've also worked in some PCBH like models in the past, providing some measurement informed care efforts, screening patients, and providing brief interventions. And then I shifted my attention over to leadership, operations, and now I help support implement collaborative care across the country. So happy to talk with you all. So, before we dive into today's discussion on the collaborative care model and its application with pediatric patients, we would like to get to know the audience a little bit better. I would love if you could all just take a moment to share your role, your organization, the state that you're in, and then just tell me a little bit about the familiarity you have with the collaborative care model on a scale of 1 to 5, 1 meaning you have no familiarity. This is the first time you've heard about the model, and 5 being that you're an expert in the model. So again, your role, organization, state, and familiarity.
Since we have over 30 people, maybe people could take the opportunity to unmute or to put in the chat. Were you meeting in the chat, Nicole, or were
Yeah, in the
you?
chat. So sorry.
Yeah, I was like, oh
That
boy.
we'll take the whole time doing a round of introductions.
Yeah,
Thank you for
I was
clarifying.
like, sorry about that. I was like, yeah,
100%. Please just throw
yeah,
that in the chat, just, so we know who we're chatting with today. And as questions come in, we can gain
love
some
that.
insight there.
Yeah, love that.
Um, so thank you all for sharing those details. I'll let you all kind of throw that information in the chat. Throughout our webinar today, we'll be covering several key slides that detail what collaborative care is. So going through some of the basics, its core principles for those that have a little bit less exposure to the model. And then we're going to go in depth in some of the evidence supporting it and also the clinical workflow specifically for pediatric populations, which I think will be really helpful for the team here today. We'll also ensure that there's plenty of time for discussion and questions as we go along. So let's get started in exploring the model and a little bit about the team dynamic. So collaborative care, or CoCM, you'll hear me calling it very often, is more than just a service. It represents a team-based, data-driven, patient-centered population health approach to integrating behavioral health into primary or specialty medical care. Often, terms like collaborative care are used interchangeably with interdisciplinary care, working with others, teamwork, or involving patients in treatment planning. And while these elements really do enhance care, they do not alone constitute the delivery of the collaborative care model. So, we're going to unpack that a little bit today. To deliver full fidelity collaborative care, it requires some specific infrastructure, a defined team dynamic, and established billing codes and adherence to specific payer requirements to maintain fidelity to the model. If you're interested in a deep dive or a comprehensive list of all of those considerations to prepare for implementing in collaborative care, if your organization's at that stage, we have some resources for that we'll drop in the chat towards the end of the session today. But a common visual representation of the collaborative care team is this triangle diagram that we see on the slide here today. This triangle you will see everywhere that collaborative care is. I'm pretty sure that anybody who's worked in collaborative care for a few years has this tattooed on their arm somewhere. It is a great way to represent who is a part of this collaborative care model. And if any one of these team members is missing from the model, it's not really collaborative care. So let's kind of break down this diagram. First, we have the patient who is at the center of this model, not the clinician, not the psychiatrist. Everything we do is really focused around improving the patient's mental health outcomes. Next, or actually, before I move on to the next team member, you'll see within that triangle as well the guardian. So the parent or the guardian is also present in the middle of that triangle because very often when you're working in pediatric care, you also have to consider the guardian. They're often involved throughout the course of care. You may need to have them help with engagement with the patient, providing additional context or information. We may need to provide updates if there's any safety concerns or updates that would be helpful. Sometimes there's even some skills coaching that's involved in this model with the guardian. So they're in there because they're very often going to be involved in pediatric care. Next, we'll see at the top of this triangle, the primary care provider or the pediatrician who remains that clinical leader for the patient's overall medical and mental health care throughout this process. They are the prescriber for psychiatric medications, but they are supported by a team and not operating alone, which is a really important aspect of this model. In the bottom left-hand side of the triangle, we'll see the behavioral health care manager. The BHCM plays a critical day-to-day role. They're going to be conducting regular symptom monitoring. They're going to be providing brief behavioral intervention, supporting adherence to medications. They're going to be coordinating communication and between team members, and they're also going to be maintaining the patient registry, which we're going to talk about a little bit later when we get to the registry on here. But that will help them to track the progress towards treatment goals and update treatment recommendations with the psychiatric consultant as needed. We also see in the bottom right-hand corner the psychiatric consultant. The psychiatric consultant does not routinely see patients directly. Instead, they review patient registries, consult on complex cases, and make treatment recommendations back to the PCP and the behavioral health care manager. They're going to be meeting on a weekly cadence with the behavioral health care manager to discuss patients that are not improving at the rate that we want to see them and building updated recommendations, essentially. This approach really extends the psychiatric consultant's experience across a population of patients rather than just focusing on one patient at a time, really expanding the access to care with psychiatric recommendations. And then the registry, our unsung hero in collaborative care. The registry is the engine that makes this model work. It allows the team to systematically track and manage a population of patients. Without a registry, you cannot really have true collaborative care. It's the difference between managing one case at a time versus managing a whole panel for symptom improvement. So this registry will help you to monitor those symptom measures that you'll be applying in this model if you're a behavioral health care manager, seeing if the patient's improving, if they're plateauing, or if there's experiencing an increase in scores, and that will help you make decisions. It'll also help you to track engagement to make sure that patients aren't falling through the cracks. So it has a really important function in this model and is a really important tool for the behavioral health care manager to update and utilize on a regular basis. You'll see some solid and dotted lines in this triangle, just really briefly going over that. The behavioral health care manager will have frequent contact across the full care team. The patient, the guardian, the PCP, the psychiatric consultant, they'll be contacting them all directly in different spaces and capacities. Whereas the psychiatric consultant, for example, is going to have little to no contact directly with the patient and little to no direct contact with the PCP. They're going to alternatively be electronically sending recommendations to the primary care provider, and then they'll be gathering information through the behavioral health care manager, which they will use to build their treatment recommendations and send those updates to the PCP. So in short, collaborative care is not about referrals out, it's about building capacity inside your primary care team to systematically identify, treat, and improve behavioral health outcomes. Every member of the team has a defined role, and data is what really drives continuous improvement, utilizing and leveraging that registry. So I'm just going to pause there. Thank you all so much for throwing in here where you're located and some of your understanding. I'm seeing a lot of varied responses here. I see some experts in the crowd, which is exciting. I see some that are a little bit newer to the model, which is really great. So we're definitely going to have some space for some more nuanced questions as we go through this. But I'm also happy to see that we have some that are going to be benefiting from some of this more general overview of the model as we discussed today. So the next thing that I want to talk a little bit about are the principles of a collaborative care model, which are crucial for delivering high fidelity care as they establish that framework for effective integration. There are five principles to consider. So, first, just to go over these briefly, we have patient-centered team care. All care delivered in the collaborative care team, to the extent possible, is with the patient's interests, preferences, and schedule in mind. So, we're really building a lot of flexibility in this model. And again, we're keeping that patient at the center of that triangle, really working to improve the outcomes that they have in this care. Next, we have population-based care, which you can see here in green. Um, Collaborative care really leverages a care team to screen an entire patient population and influence the care of far more patients than they would be able to see working on their own, allowing a whole population of patients to be carefully managed and enter treatment more quickly and preventing patients from falling through the cracks. You're going to see some of that when we look at the workflow later, some of that identification of patients and tracking over time. In addition to this, we have measurement-based care as another principle and treatment to target. So measurement-based care is the idea that we track the patient's progress and make changes to the treatment plan accordingly. This includes treatment to target, meaning that when the patients improve according to evidence-based metrics such as response or remission, they're able to then be discharged back into care as usual. So the PCP managing their care essentially and not having the collaborative care team involved. For those who might be a little bit less familiar with maybe some of those treatment to target response and remission. A response, for example, could be a 50% reduction in the assessment scores. If you're using, for example, a PHQ-9, they start at a 20 and they reach a 10, they would have demonstrated a response. And then in remission, it's indicating that the patient has reached below a certain score on those symptom measures. So, for example, in the PHQ-9, often organizations are looking for patients to have less than a score of a 5 or less than a score of maybe like a 10 on the PHQ-9, depending on the organization standards. And then we have accountable care and collaborative care. The clinical team is incentivized to provide high value care as opposed to high volume care. The team may regularly be presented with data on patients' treatment progress, providing opportunity for clinics to continuously improve their treatment strategies. And then last but not least, though, one of my favorite, collaborative care itself is evidence-based. And additionally, the model incorporates other evidence-based treatments, including medication prescribing guidelines and brief interventions like behavioral activation, problem-solving techniques, and motivational interviewing. And Verna's going to talk a little bit about that collaborative care evidence base a little bit later in the presentation. So I do just want to pause here because while we've only been a few slides in, that's a lot of information. So just want to see if there's any questions before we move on to the next part of the presentation. All right. If you do have a question, feel free to come off mute. Otherwise, I will jump back in. Verna, anything to add in there before I jump into the next slide?
No, I will, no,
Excellent.
fabulous.
All right. So now I want to take a little bit about talk a little bit about the evidence supporting collaborative care. Really briefly, collaborative care is extensively evidence-based model for integrating mental health treatment into primary care, and also other specialized populations. There are over 90 randomized controlled trials corroborating the efficacy of the model across the diverse populations and settings. And the model also incorporates evidence-based treatment guidance, as I had mentioned previously in the principles. There is also some specific evidence related to pediatric populations, which is where Vern is going to jump in a little bit later. But I do want to focus in and delve into the differences between collaborative care and treatment as usual for a moment. Um, We can see here that we broke it down into a couple of different categories: care approach, patient engagement, access to psychiatry, and outcomes. I think we all know that that primary care providers and other specialists are working incredibly hard and that they're doing so much, and they are often taking point in prescribing medications and linking patients to referrals. And when we think about treatment as usual, that's what we're talking about. Um, so when we consider care approaches, for example, the collaborative care model is proactive and employs team-based approach. In contrast, treatment as usual often places that responsibility again on the of that patient care on the clinician, the PCP, or that specialist who really will be handling those referrals and external services. This often results in a lack of continuity as clinicians may not be aware of what services the patients are receiving outside of the practice, may not have releases to communicate always with those organizations. And sometimes patients will also fall off of the referral track. They receive the referrals from their providers, but through lengthy wait lists or just not taking that space to connect with those referrals, or having difficulties accessing those referrals, may not connect successfully. When we think about patient engagement in this model, collaborative care often includes some systematic follow-ups and monthly measurement-based care, which will really allow for close tracking of patient progress. This process enables the team to identify when a patient requires updated treatment guidance. On the other hand, when you're engaging in treatment as usual, it can be a little bit more reactive. Without ongoing monitoring, those ongoing sessions, primary care providers can really only respond to information presented during scheduled appointments unless they are providing additional outreach, which is often difficult to manage with PCP's busy schedules. And then in collaborative care, the psychiatric consultant is a really integral part of this model. It's integrated into the care team, and they're meeting weekly with that behavioral health care manager. So it's built into the model, it's baked in. This collaboration means that if a patient's symptom measures spike, or they report that they have some concerning side effects, or we observe that they're not doing well, we can really discuss these issues. And within a week of observing those issues, because we're meeting weekly with the psychiatric consultant, build updates to their treatment plan. Whereas in treatment as usual, patients must first be linked with a psychiatrist, which we know can often be a really lengthy process. And then finally, let's talk a little bit about outcomes at the bottom of this graphic. Collaborative care, we see improvements in symptom reduction, treatment adherence, and access to care. In treatment, as usual, we see some varied outcomes, frequently tied to challenges in access to care and engagement. Again, PCPs are working incredibly hard to support patients with their behavioral health symptoms, but because they have varied availability to provide some of that direct support to patients, sometimes we see varied outcomes, and also that lack of ability to follow up as closely as a BHCM because it's a part of their role. You can see again the varied results there in the outcomes and treatment as usual. So now that we've unpacked some of the basics of the model, some of the principles, what that team dynamic looks like, I'm going to pause here and I'm going to actually pass the mic over to Virna Little to talk a little bit about the evidence base and the collaborative care model in action.
Sure, thank you. Um, and I think you're going to keep doing the slides, or am I going to do the slides?
We've got you.
Okay. Uh, so a couple of things as we think about the evidence supporting collaborative care and treatment as usual. I wanted to just take a moment because when I think about evidence, I also think about what we've been able to write about evidence and sort of what we learned. And we have learned a lot about collaborative care and some of the implementations and things to collaborative care. So a couple of things that I think would be helpful to talk about. So when we think about the approach to collaborative care and what that looks like, one of the things we've learned and the magic of collaborative care is really this concept of doses of care. And what we've learned is that it's the number of contacts that are really important versus the amount of time. And so one of the things we've seen in some of the larger data is that you have a 13% greater chance of a good outcome and engagement with every contact. And so that's why we think about one or two contacts a week for the first couple of weeks of treatment. You can keep it here, Nicole. This is kind of the slide I was, and so this is the kind of research that we're doing to really understand some of these best practices. We're also looking at the ability to be able to look at different populations. So we have looked a lot at kids with ADHD or ADD. And one of the things we found in implementations is one, that this is incredibly effective, but that a lot of practices actually aren't really monitoring kids. They're like, oh, I give meds. I've been doing this for years. It's not a problem. And that when we actually do the Vanderbilt, well, we're like, actually, the hyperactivity got better. So everybody thinks we're better, but really, we're not as good as we could be, right? We don't want to be here. We want to be as good as we could be. And so we see the effectiveness for collaborative care. It's there for the population. It's really just getting the practices and the providers to really understand what it means to manage their population of patients with ADD. Like we would never have a whole population of patients of diabetics that we put on metformin and we never looked at the A1Cs. We're like, oh, I think they're better, right? Like we wouldn't do that. But the reality is pediatric practices don't really measure. And a lot of the time is that, well, I can't get the Vanderbilts, I can't do this. Well, that's the whole point of collaborative care, right? That we're putting a system in place. So we see tremendous. We also see a lot of results for children and adolescents with depression or anxiety. We see tremendous improvements. And my theory here is that it is the doses of care. One of the magic of having that monthly case rate, that is a gift. And that is because as a clinician, I can teach most behavioral health interventions are 6 to 8 minutes. I can teach a DBT skill, call and follow it up, teach breathing, call and follow it up. How did it work? Oh, it worked good at home. It didn't work good at school. Okay, let's problem solve it. And so for adolescents in particular, it is so helpful to have those short, frequent telephonic touches. That really makes the difference and sets collaborative care out from usual care. I use all of my clinical skills, all my BTs, I like to say, right? But I use them in doses and I use them strategically and then follow them up. And so that's why in school-based health centers and some of the others with pediatrics, collaborative care works so well. And when I think about kids at risk for suicide, teach a DBT skill, follow up, review a safety plan, follow up. The doses of care in that monthly case rate are incredibly helpful. And we see this in urban and underserved populations. We also see that kids are more likely to keep these appointments. And one of the things that we hear a lot from clinicians is, oh, it's actually lesser care. Collaborative care is lesser care. And I don't think of it as lesser care. In fact, I actually think in some cases it's higher because of the doses, but it's really one evidence-based practice versus another, right? And the reality is for pediatric populations, it is way more effective. And also, I think about the work with families, the ability to get on the phone with a family, problem solve, and then follow up the next day. And so, a lot of times for the thinking about what happens with children and families, there's still this misconception that phone is sort of lesser care. But I was talking to an adolescent the other day, and her family totally stresses her out. And we went outside and we practiced our breathing outside. Breathe in, breathe out, box breathing, did it. And she said, it's still, I don't think I can still hear everybody yelling inside. Where could you go? We walked a little bit farther. We found a place to sit. We did our box breathing, right? Then, what could we do at school? I did that with her right on the phone. I wouldn't have been able to do that in a different setting. And so, really getting you to think about collaborative care in a very different way. It is so much fun to be a clinician in collaborative care. And the research over and over again says that it's more effective, but that kind of makes sense. Go ahead. So this is the workflow. This is very pretty. Meadows does incredibly beautiful things for collaborative care, like unparalleled beautiful things. And so you can see it. I just want to sort of talk about it high level. There's a couple of, I'm going to call them mistakes that organizations make. And I'm going to just for 2 minutes stop here because we have a lot of folks that are implementing. One is it's so important to get your script right with your referring providers. I work with Nicole. She helps me care for all of my patients who are feeling anxious. I'm going to have her give you a call later today. You're going to love her. She's fabulous, right? I'm not saying what collaborative care is. And in fact, as a clinician, I never tell people what collaborative care is. Nobody cares. And so it's kind of like people just want to get better. Tell me about sad. Tell me about anxious. And then I kind of jump in. A lot of times people say, well, it's not therapy, it's brief, it's that. When you go into care, you don't want to hear what something is not, right? If your oncologist said to you, it's not radiation, it's not this, you're like, I don't care about that. I want to know what am I getting and how good is it going to work, right? Like just care for me. And so the other piece is really getting your care programs to not be just dependent on a warm handoff. A warm handoff is nice, but collaborative care is about population of patients. And oftentimes people depend on just warm handoffs to populate their collaborative care. And that doesn't work often. It doesn't give enough sustainable patients. So, like, what population health approaches, everybody with ADHD, everybody getting a med, all of this. So, how does that really piggyback onto your screening programs? Everybody who's positive, what does that actually look like? Because the biggest mistake in collaborative care, Nicole, I'm older, so I probably have more, but Nicole probably has her stories. Collaborative care doesn't work. It doesn't work. We tried it. It doesn't work. People don't. And a lot of times what happens is we don't get enough people. And then care managers don't stay because it doesn't seem clear, providers don't refer. And so what we've learned is that what happens in the first 2 or 3 months of implementation makes or breaks a collaborative care program. If you do not, and I just use the word program, and I don't actually like that program service line. I don't know why I said that, but if you have a care manager and they are needing to get to a full caseload, which for peds is about 75, 30-month one, 60-month two, 75-month three. If you do that, you will have a successful collaborative care program. If you don't, it will be the bane of your existence. And you will go to the land of perpetual launch. You have greater likelihood of losing care managers. This way, you understand the caseload, providers get what it is, your billing people go, oh crap, I better figure this out. I got more coming, and then you're going to be successful. So if you're in the process of implementing, that is so incredibly important. And Meadows has a ton of resources to be able to support some of that. But this workflow is incredibly important. Get your scripts right and then look how many providers are referring your 100% and how many of those referrals turn into cases. Because if they're not converting from a referral into a case, it's likely your provider script or your care manager engagement. I don't know, Nicole, if you have anything you want to add about workflow.
No, I just want to echo that. I think what you talk about related to making sure that you have a really productive first few months is really important. I think something that I often see organizations lean into is saying that, oh, they just want to see how it goes. The providers are super motivated. They want to depend on that intrinsic motivation. And, my experience has been that while that motivation is wonderful, we do need to make sure that we have the right tools that are BHCMs are focusing on that high quality, really productive engagement with patients from day one, because that really is some of the levers that can be really powerful and keeping patients in care, but also getting referrals in because patients will be enjoying care. They'll report back to their PCP. The PCP will be like, the model's working, and then they'll send more patients, and it'll
Yeah.
continue to kind of snowball. So I agree with you. I think having a really good early start, making referral volume and ongoing engagement a priority from day one is incredibly important.
And what Eric put into a lot of times people say, oh, we're going to have this soft launch or one provider. No, no, that actually doesn't work. Like we used to think that worked years ago. We don't do that anymore. If you're going to do it, do it. roll it out across a practice and really get it to be effective. And then some of the process things that you look at, the conversion from referral to first month, and then from first month to second month. If you don't have a lot of people going from first month to second month, then that's an engagement issue. Maybe that's us spending a lot of time telling people what collaborative care is or what it isn't. That also, if we do a more traditional mental health intake, we tend to lose people because the part of what really makes collaborative care effective is that people have choices in collaborative care. So I can get talk treatment, I can get medication support, goal setting, symptom monitoring, and people can move between all of those treatment choices. And so oftentimes I'll ask practices, well, tell me how you schedule people. And they're like, once a week, every 2 weeks, once a month. And then I'm like, you're not doing collaborative care because everybody's schedule should look different. Nicole's in symptom monitoring. Patricia, we're doing goal setting. We're talking every other day. Kira at Montefiore there, we're just talking about medication support, and then maybe we set some goals. Someone else is in talk treatment, maybe once or twice a week. And so it's going to change for everybody, and it's going to change as I go through care. So there should be no consistency. And a lot of times we wind up with really a version of therapy for everybody. And we lose people, particularly pediatrics. So we did something with the practice that I'll just share very briefly because I think it'll say it is now summertime, right? Schedules change, kids change out of school, everything gets turns upside down, right? So that we did something where we said to families and to kids, listen, summer is coming. We're meeting now regularly, but summer is coming. How should we change, what we're doing together? What would be helpful? And a lot of times people saying, well, you know what? Let's just stop for the summer and we'll regroup in the fall. Very common. And to say, it's really important that we keep your provider in the loop. We have a way to measure how you're doing. And so what I'd like to do is just talk to you once or twice a month, ask you some questions. When's a good time for that to happen? Is early morning good? Is later in the day good? And sealing that deal. But having the intentional conversation and making sure people always know they have that choice just to go to that symptom monitoring sort of stage. And people say, well, don't we always do symptom monitoring? We do, but in that treatment choice, that's all we're doing.
Yeah, I agree wholeheartedly there, Verna. I think that patient choice aspect in collaborative care is so valuable, that flexibility that this model offers. Being mindful about overusing clinical language too can be a really important area of this. Let's talk to people like they're people. We want to be professional, of course, but we also want to be authentic and establish rapport, and we want to do that as soon as possible. So, especially with a pediatric population, making sure that you're engaging in speech that works well for the group and the individual in front of you. And I love the idea of, getting into the session as soon as you start it. Tell me a little bit about the anxiety that you mentioned to your PCP. I want to learn a little bit more about it. And starting from there versus from, all right, we're going to talk about your whole prior medical history.
Mhm.
Tell me how many times you've been in the hospital this last month. That's a lot for a first engagement with a patient. And you have the opportunity to break up the times that you ask those questions. You may need and want that information, but you don't have to get in the first 5 minutes of a conversation with a patient.
Yeah, I would say a couple of things too about I've learned to use the tools as getting my information. So you're feeling sad. How long have you felt sad? When haven't you felt sad? Do you fall asleep and not stay asleep? So I'm like doing a differential, getting ready for psychiatric consultation while I'm doing the tool and kind of figuring that out. The other thing that I'll share, there's a gentleman, Cody, who is a CFHA member and a fabulous human and clinician. Um, and he actually did a training recently, and I will not say it as eloquently as he did for pediatric care managers, but we were talking about the initial assessment, and he said, I get wanting to get the story, and then you have to kind of move the tools in. He said, but it is such a gift to use the tool to get the story. And that actually allows me to have a better relationship and be more effective because I'm very intentional then about the information I'm getting and the relationship that I can build sort of through that process actually winds up better than me getting the story and trying to figure out how to use the tools. And so I'm going to record him saying it because he said it way better. But it was incredibly interesting to hear it that way. And I thought the people in the room were really affected by it. Actually, my friends from Montefiore were there. So if I did not do that justice, I'm sorry, but you were all there.
That is a really lovely saying. I love that. Um, Verna, I see a couple of questions popping in the chat. Do we want to take them before moving on
Yeah,
to?
sure.
Okay, from Samantha Hamburger, I believe at CNH. Do you have experience? Ooh, the chat's moving on me. Do you have experience, insights about engaging children virtually, especially younger children? I don't know, Sam, if you want to come off mute really quickly and tell us a little bit about the age range that you're referring to when you think about younger patients.
Yeah, sure. I'm working with kids that are like 6 to 21. So
Mhm.
that whole range and each like range has a um different needs and yeah, I've been doing like a lot of virtual work with people. So
Mhm.
some who I've met before, some who I actually haven't met before, but am like engaging with uh mostly over the phone, a little bit over video. And so I'm just wondering if you have like insights, best practices, things that you found really work.
We do going to your screeners and your tools, right? Because we're going to show it next, but there is a pediatric group that are and a lot of CFHA members that put together a pediatric pathway that we'll share that actually has very detailed information on the tools and what ages and the research and all of that meant to be a guide. And I think we've done a lot of trainings about doing virtual care like video or phone. And you do have to be a little bit more proactive in terms of, if a child's distracted or they're on the phone, sort of calling it out. But it does allow you to engage other family members. It allows you to do activities. Me personally, particularly for the younger ones, I find it better if we're doing something together. That way they're not doing something else or they're distracted. Tell me about something that you're drawing, or if we were going to go outside, what would be helpful for you so that we're doing something. If you're your mom and I'm you, like we're back and forth, we're role playing something that we're doing an activity versus like something that might look a little bit more traditional. Um, and Ross, just to take this billing question, how do we manage billing when we move to symptom monitoring and only have, for example, two 15-minute phone calls a month? So 60 minutes in a month. So remember a couple of things. One is that the half plus one rule. So it's really 31 minutes a month. And so if I have two 15 minutes, I have psychiatric consultation, I'm updating my registry, then quite often you do make that 99493 code. As an example, if not, you could use one of the others, but certainly you'd probably make your 31 minutes.
I also went ahead and dropped a Billing Basics flyer in there for you. Ross, if you have any questions, of course, feel free to reach out to us or ask additional questions here. Um, I want to circle back to the question about engaging children virtually and screening. I agree with Verna. The handout that is linked here is a great starting off point. If there's some additional information that you need there, Sam, feel free to reach out to us. But in regards to engaging pediatric patients virtually, I think that and I actually think I see this reflected in Kira's a mention here as well. Like there is a lot of really wonderful flexibility in this model and the ability to engage with a couple of different stakeholders in pediatrics. So you have the ability to, maybe reach out to the pediatric patient for a 15-20 minute check-in after school. And maybe you do a virtual session where you do an activity collectively, like Verna was referencing, or maybe we're having a quick text check-in one day when they don't have the ability to meet with us so that we can at least check in and see how they're doing, check in on how they're progressing towards their goals, assuming that you have text or some kind kind of secure messaging service. You have the ability to connect with the guardians during the workday and say, hey, I just want to talk with you 15 minutes about what's going on with your patient, Kayla. I want to see how she's feeling and how she's presenting at home, get a little bit of information, see how you're navigating some of this care. If you need to have a quick 5 minutes to talk about some skills that we could build together to navigate some of this. So there's a lot of opportunity. And, one of my favorite parts about this model is it's just fun. You get to really engage a lot of different engagement techniques. You get to communicate through a lot of different avenues. You can really creatively build therapeutic environments with your patients through these virtual modalities. And you can also deliver services in person, assuming that your clinic has the resources for that. But it really does give access to care for patients that otherwise wouldn't have access to a card to get to your clinic or just doesn't have the time to spend an hour to like get there, check in, sit in the waiting room, meet with you in this very clinical environment. And then, like, I can jump on the phone with you and we can chat about things that interest you and get and talk about your anxiety and give you some concrete tools, practice it together. You'll practice it outside of session. I'll send you a text check-in, and then next week we'll talk about it a little more and maybe learn something different. And I'll be communicating with your guardians, engaging. So there's a lot of beautiful creative work that can happen in this model.
Without a doubt. I'm looking at the next question. How do you manage billing when the child doesn't meet criteria for a major diagnosis? So, just like with any treatment, right, you have to have clinical necessity in order to bill. And so you do have to have a diagnosis in collaborative care where there's a validated outcome tool. So ADHD, PTSD, there could be anxiety NOS, it could be but like any treatment, you need a diagnosis for clinical necessity to be able to do that. And also, I would say long-term outpatient therapy. Um, One of the biggest adjustments to outpatient care after collaborative care is that people have to get used to just once a week and not having any other contact or any other support in between. So they actually have to kind of adjust to that unless they're going into a day program or doing something. And I would have to say most kids, so I usually don't do this, but I happen to have very specific data. For my company Concert, we send less than 5% of the people out, pediatrics out for any specialty care. And that's usually a day program where a kid is cutting or like there's an eating disorder or something where they need like an actual specialized, after school programs, occasionally inpatient, but most kids actually stay and do really well in collaborative care because of the skills that you can give and reinforce. So it's very few and far between that you would really transfer kids like into different care.
I would agree with that, Verna. Often when I had a patient where originally when we first start working together, there's an indicator maybe they need some specialized care of some sort. Through working together, very often we get their symptom measures to a point and how they're presenting to a safe space where they can continue to work in collaborative care. On the occasion where I did need to link patients to and bridge them into other care, because collaborative care can be a great space for that work. I'm providing a lot of education about the different modalities that I'm linking them with. So I'm not just giving them a list and saying, all right, good luck. No, one of the value of this model is I can support in that care coordination. I'm, researching uh, referrals that are adequate for the patient, their preferences, and their payer. I'm coaching the patient on how to or their guardians on how to have that phone call. Sometimes I'm even calling together with them if I'm seeing that
Mhm.
they're having challenges reaching out. And I'm educating on what that first session will look like. Often I had patients that would get to the intake session and then they'd call me back and they'd be like, I hated it. I'm never going again. And I'd be like, intake sometimes feels like that. Let's normalize that. Let's make it to another session and then let's see how we're feeling because there is a session after this that feels a little different. And giving them a space to debrief that a little bit of overlap, and then transition into the next program, I found has been very valuable in the care that I've offered with patients. So, a couple of tidbits there for how to prepare in the case that that specialized care is needed. very often I have found though that before we even get there, we find that they don't need it anymore and that the space has helped them to the point where they can continue and complete this line of services. It
And
does.
remember, like for trauma or for kids who are cutting, you can do DBT and follow up. You can do exposure therapy and follow up. Like there's very few clinical interventions that you can't do in collaborative care that you wouldn't do in outpatient treatment. The difference is I'm often giving them in doses, but not always, right? So you have the ability to do that. There's a question in here about advocacy to support payment. Oh my gosh, I spend every day, all day doing this actually. Very excited, not that it matters to the pediatric population, but the CMS proposed rule has a tremendous increase for collaborative care in it for Medicare. So we are actively working with the states now to say, hey, are you going to follow Medicare with your state rates, even if they're not paying the full 100%? Nicole's team and I spend a good part of our day every day doing advocacy work. I was in DC 2 weeks ago. And so if any of you here are in particular states or are having difficulty with particular payers, please reach out and let us know. And I'm glad to do that. And I often post out on CFHA advocacy opportunities. I sent something the other day with a survey to fill out, and I said, call out collaborative care, tell them you want the copays waived, right? I'm going to be sending something out very soon for you to personalize and send into CMS for the proposed rule change. And so I always share those things and opportunities, but feel free to reach out and feel free to ask questions.
I'd also suggest just, following Virna on LinkedIn and just keeping an eye on some of the interesting posts that she has, and you can see some of the wonderful work that's happening. And she truly does lead the stride for advocating for collaborative care and making sure that we're top of mind and that changes that are necessary are being made. So,
I think we're going to share the pediatric pathway as the next slide.
yes.
This pediatric group is really a labor of love. People that came together to build this pathway did hours and hours of work at no reimbursement. They just got together, said we want to help organizations do pediatric collaborative care. Meadows was a part. Jill from Mira, some CFHA members, Cody, folks from around the country came together, did a comprehensive review, put together a pediatric pathway that could be a real start and a foundation. We shared it for free out on CFHA. We present it each year at the CFHA conference so that you can go meet folks, you can be a part of that process. We now have other special interest groups. We have addiction, we have geriatric, we have women's health, we have early childhood. We're starting an ADHD one, and then we have a general research group. So these are special interest groups that run, and they are putting together pathways that will resemble this one. But for here, what we did is we took all the tools that were out there and we said, which ones are validated for screening, which ones are validated for symptom monitoring, which ones are validated for diagnostic, which ones are validated for outcomes, because for collaborative care, you kind of need one that does them all. And then we broke it down to different ages, sort of the 12 and up and the under 11. And so that is all put together here with some thoughts. Most practices use the pediatric symptom checklist. There is ability to have outcomes with just that pediatric symptom checklist, or to be able to use, if they pop for anxiety, to use the SCARED. So this takes you through that. And can be helpful. It is available on the Meadows website. I think it's on some others as well, but Meadows definitely has it. And then every time it's updated, either Meadows or myself shares it out on the CFHA listserv.
So I believe that's the material that we have today. Verna, anything else that you want to share about the pediatric collaborative care pathway?
Do we suggest that PCPs refer all patients with behavioral health diagnosis? Yes. I would say it depends. So the question from Mark in the chat, it depends on if folks have existing behavioral health resources and collaborative care, because then you might want to say in a pediatric practice, ADHD, depression, anxiety, go directly to collaborative care. And then other diagnoses may go here. What does not work is to have a behavioral health person take the referrals, do an intake, and then decide whether or not they should go to collaborative care. That is not a good workflow and is often not successful. You're better off just to shift it. But yeah, actually, if the only model that you have in a practice is collaborative care, then absolutely most patients are going to be fine. And we have a list now of diagnoses and outcomes that are good for collaborative care. So you have suicide, you've got bipolar, you've got PTSD, depression, anxiety, ADHD in adult and kids, you've got bipolar. Like it's a pretty expansive list now of diagnoses that can be included in collaborative care, and there's research to support that.
Any other questions from the audience? These are wonderful questions, by the way.
Yeah, I love it. It is a lot of fun to be a clinician in collaborative care because you really have the ability to do so much, like really whatever works for that person and switch it on and off. 3 times a week, once a week, twice a month, like it can vary and it can change, I could be in therapy for 1 week. That's cool.
Yeah, I think as a clinician, it's really wonderful to be able to see your patients improve too, and to be able to take that journey with them in such a short time and feel like it's a really productive space. Kira, I think you had your hand up. Go ahead. Oh, I can't hear you.
This is Kate. I had my hand up.
Oh, Kate, I'm sorry. Kira
No, that's
popped
okay.
up.
No worries. And apologies for I'm having some apologies for banning camera. Verna, what you were just saying about how much fun it is to be a clinician in this model, can you point us to sort of some is there any, especially in pediatrics literature, about things like clinician satisfaction, people staying in practices? I know we're early days, so there may not be yet, but I think this is something that like I have been thinking about and grappling with a little bit as sort of part of the I agree with you, super
Mhm.
fun, etc. But in terms of thinking about this as a lever to actually help improve the work life and the satisfaction of behavioral health clinicians in practices, especially when there's only one, right? When you're a
Yeah.
clinician in a practice. And I'm just wondering if there's anything in the sort of literature or sort of white paper
There
that
isn't. There is not. But
publication opportunity.
yeah, well, what I would say, if there's anyone on this call that is interested in working on that, to me, there would be a strong correlation between are you practicing the model to fidelity, right? Where you really have the treatment choices. Because if you're going to have a caseload of 75, you have to have people in all of the different treatment choices. Like if I'm seeing people, like it's not tenable if you're just doing outpatient mental health and that's what you've recreated. And it's certainly not as much fun. And so I think if there's anybody on the call that is interested in that, email me. We will pull everyone together. It could be part of the formal national research group, and we have resources to be able to write a white paper, maybe do a survey across CFHA or practices doing pediatric care to do some qualitative interviews. Like I would totally ante that in with you, and then we could figure that out. So if people are interested in that, then absolutely email me.
Thank you.
Um, Also, last year at the CFHA conference, we were doing a presentation on workforce and sustaining the BHCM in the collaborative care role. And we noticed the same thing. There was a lack of any written material or clear research, really flagging what keeps a BHCM in the role and happy in the role. And holding that sustainability. So we did do an informal survey at the time with CFHA. Actually, we sent it out to you all to see what the experience was in collaborative care environments with the behavioral health care manager. Just from memory, since I have not looked at this informal survey in a little while, something that we did see very often, a common theme was BHCMs just feeling prepared in the role. They wanted to have adequate training. They wanted to know what they were doing. They wanted to know how to support their patients. They wanted to know what they wanted to be in the surveying collaborative care and fidelity as well. They wanted to make sure that they had that ability to really organize their patient panel adequately because they're working with a high volume of patients. So those were big ones. And then of course there's always things like incentives and keeping individuals motivated with appropriate work benefits and salary and things like that. So making sure that you're paying individuals for the education, the licensure that they might hold in the model, and selecting individuals mindfully in that way were some early things that we were identifying there. But I do think there's a lot of room for some additional research, and I love the idea of some key informant interviews or something that can give us a little bit more insight there.
Does it matter whether they're master's level or whether they're not? Do you have, no, Verna's shaking her head.
It doesn't, scope changes certainly, but a lot of the interventions, some DBT skills, problem solving treatment,
Sure.
behavioral activation can be really trained up for, bachelor's folks. And I love this for master's students. I think it teaches them to be great diagnostics, to really be very, use a lot of different modalities and work themselves into a job. So most states allow for those providers to bill.
Great, thank you.
Also, just dropped a couple of resources for training. There is an online self-paced free training available, developed in partnership with West Health and Northwest Medicine's apologies, and the Meadows Institute that provides some online training for the behavioral health care manager role and also the psychiatric consultant role, the PCP role, and billing professional. So 4 separate trainings. I would check those out. And then we also have the BHM licensure requirements for all of the states, Virna, and Meadows Institute, and many others in CFHA supported in kind of capturing what are some of those licensure requirements that exist out there so that you can select behavioral health care managers that you can then reimburse for, and if you're working with state Medicaid.
And also, if you want information on your state, what your state does around collaborative care, you can reach out. But on the Meadows website and on the Concert website, there is I don't remember what we call it. I think we affectionately call it the state grid, but it is out there and it clearly defines what each state does around collaborative care. And we update it all the time, and then we go through it as a team quarterly. So it's kind of the latest and greatest information.
Right, I see that we have 3 more minutes. I'm just trying to scan really quickly to see if we answered all the questions. I see, Patricia, you mentioned we offer PCBH and are working on implementing CoCM. Are there any features or cutoffs that you would utilize to identify which service line may be more appropriate?
I think you need to think about diagnosis, like depression, whatever diagnoses you're going to include in your collaborative care service line, they just go right to collaborative care. People can do a little sorting on the back end, but I think I could see people briefly, a couple of times a month or, not, but I think that's a better way to be able to do it.
So I see we only have 2 minutes left. So just kind of to close out this space today, I you really enjoyed this conversation. I really appreciate I know Verna does as well. We appreciate the invitation to do for this cross SIG opportunity. Really encourage you to visit the collaborative care special interest group as well if you're interested in collaborative care and would like to learn a little bit more and just hear what folks in the field are working on right now. Some of you probably are already members based off of some of the experience in the chat. if you're having any trouble, if you have more questions, we did not have time to answer all of them. This was such a great environment to chat today. I think we ran out of time. Reach out to Verna and myself. We, love to talk more and, just support you in getting linked to the right resources to support an implementation or even enhancing models that might be existing. I don't know,
Yes,
Verna, if you have anything.
Connecticut, shame on Connecticut for what they just did. We're in the process of figuring out how to yell at them big time because they're the only state that made such poor decisions. And so yes, but thanks for bringing that up. And that's where the state grid comes in handy.
All right. Well, I believe this is recorded, so feel free to take a peek at it after the fact. And again, if you have any questions, just reach out. Thank you all so much. This was lovely.
Thank you. Have a great day, everyone. And thank you, Nicole. Fabulous job pulling all this together.
Thank you, Verna. Always wonderful partnering.